Hi, everyone. This is Ellie Tahoney with Research America. Welcome to today's Alliance member web meeting. So glad you can join us. Thank you for being Alliance members, as always, and for joining us today. Before we get started, I'm sure you know the drill by now, but if you see a slide on your screen right now, it should show you how to mute and unmute your lines. Type your questions into the chat line anytime, but we'll be saving questions for the end of the discussion. And for those of you dialing in by phone, we'll open up the phone lines after the discussion. So our first guest speaker today is Dr. Nora Volkow, Director of the National Institute on Drug Abuse, otherwise known as NIDA, at the National Institutes of Health. And Dr. Volkow is also a researcher who has done pioneering work. She's been pivotal in affirming that drug addiction is actually a disease of the brain through imaging studies. Dr. Volkow, we look forward to hearing from you about NIDA's COVID response and also your personal perspective on what are clearly daunting challenges. I know you, as you mentioned, facing all of us, but particularly those that for individuals with substance abuse disorders. So take it from here.
Well, Ellie, thanks very much. And first of all, I want to really tell you that I'm very grateful to be given the opportunity to speak with Research America, which of course I've always valued enormously the job that you all have in making it clear how important science is for addressing the needs of the country. And I don't think that there's been an ever period where this was more evident than what we're living currently. The solutions will come from science, and then of course we all as individuals need to make that happen, but without science we won't be able to solve them. Now, what has been of great concern as the COVID is hitting us all in very different ways is that it is hitting the country at the time that we already have a raging epidemic of opioid addiction and deaths that we have been struggling and battling, and that basically had resulted in more than 70,000 deaths from overdoses in 2017. And these numbers are expected to rise in 2019. And with the COVID epidemic, the question that emerges is what are going to be the consequences of the intersection between the pandemic and the epidemic of opioids. And of course, it's very disturbing at multiple levels. One of them, because of the notion that we realize, first of all, that in a situation of uncertainty and high stress, as we're currently all as Americans are living, as I used to sort of say citizens of the world are living with COVID, that uncertainty generates a fear, and that in turn is associated with high vulnerability for behaviors that can be detrimental to our health. And that includes, of course, drinking alcohol, smoking cigarettes, and or taking other drugs. And if you're a person that's addicted, we know again and again that stress is one of the factors that the main contributors of relapse. And then you add this to the whole concept of social distancing, which is required in order to contain, was required certainly in order to contain the epidemic, and you get a really horrible storm. Why? Because we do know that social isolation and withdrawal is one of the factors that leads people to take drugs. And we also know that social isolation is actually what leads them to relapse and leads them to basically stay amidst the inability to get out of that stage. So in these considerations, obviously, we were very concerned about how individuals suffering from addiction will be dealing with it. Now you add many other components that makes it very worrisome, including the effects of drugs in our bodies. And we know that basically all of the drugs that people abuse influence negatively either our lungs, our heart, or our metabolism. And as a result, all of these leads to diseases that are recognized to increase the risk for COVID infection, but also increase the risks for mortality. So, and we're starting to see the emergence of the recognition that indeed there are higher rates of mortality among people that get infected with COVID that have a history of smoking. It is starting to be recognized also that the outcomes are worse on people that have any history of alcohol use disorder. We're very concerned about the outcomes on people that have a history of opioid use disorder because opioids depress respiration. And that's why you die, because your lungs cannot capture sufficient oxygen. And so if you have an infection, even if it were to be mild, and you are actually dependent on these opioids, you can foresee how that will profoundly affect the physiological consequences. That interaction may be particularly lethal. And so there are all of these concerns related to the vulnerability that individuals with substance use disorders have coming into the COVID epidemic. And most notably, again, I want to reiterate with opioid addiction, where we're already seeing very high deaths. So in that level, the pharmacological effects. And then we have the other problem that confounds it further, which relates to the structural components of addiction. Addiction is a disease that's stigmatized and for the most part still very much criminalized. And as a result of that, we have lost an opportunity to engage the healthcare system in providing screening and treatment and prevention interventions that could minimize the adverse consequences of substance use disorder. And the negative side all along of it is that in many instances, instead of providing with treatment, it has resulted in incarceration. And as we know, incarceration in itself increases the risk of getting infected with COVID. So and it also, if you're incarcerated or if you're not incarcerated and you're taking drugs, you're much more likely to end up homeless than if you're not. And if you are homeless, that increases the risk of actually becoming addicted. The stigma too impacts in terms of the lack, we know already, of the lack of use of healthcare to take care of diseases by individuals that are addicted to drugs, because they don't want to be discriminated. No one wants to be discriminated. So if they get infected, their likelihood of going to an emergency department or seeking help, we know is going to be less so. And in fact, from researchers out there in the trenches, one of the consistent findings has been that there's, beyond everything else, there's been a decrease in the visits to emergency department for people that are suffering from overdoses. So they are not going there. And that notion of stigma pertains also to other levels in terms of determining who gets taken care of and how you treat them or triage them. And those are elements that are very, very relevant. As we provide with treatment, and now that we're facing the opioid crisis, we have very powerful medications that improve, they significantly improve and protect you from overdoses and mortality and increase the likelihood that you're able to recover. But those medications are either provided in methadone clinics that require that you go on a daily basis and you are basically conglomerated with many other people, which rapidly became clear was not manageable because of the infection rate. So what happened as a result of that was that there was a permission to enable the methadone clinics to provide 1 month take-home methadone for the patients, which made it easier for patients to get access to medications. But in some instances too led to the concerns that for some individuals that are very, very vulnerable, that would result in overtaking that methadone that they take home. So we're doing this, which in principle could be a very good transformation on the way that we treat with methadone, but we didn't do it with sufficient time to prepare the support systems that were required. With buprenorphine, a similar situation. I mean, you needed to go, it was easier because you could go to a doctor. You didn't have to go to a methadone clinic, and you didn't need to go on a daily basis. But with overcrowding of hospitals and the closing of facilities, it became, and again, this is from reports that we have been able to survey across different healthcare systems, the recognition that overall there was a decrease in the capacity to provide and initiate someone on buprenorphine treatment. But as a result of these needs, one of the changes that again could be potentially extraordinarily useful is that it was authorized amidst the epidemic of COVID that you can prescribe buprenorphine to someone by telehealth, which was not possible before. You had to see the person inside. And when you are in a rural area where the transportation has been decimated, how are you going to get it? But so opening up the option of telehealth has enabled us to buffer some of these structural changes. But in terms of the element that I also capitulate a lot, and in thinking too, because we are with COVID, what also has become clear is that the horrible health disparities that exist in our country. I mean, the mortality rate of African Americans from COVID in some places is more than half when they are just a minority of the population. And we've known it all along. We've known that there are these horrible health disparities, and we seem to recognize some of the factors that may play around it. But I think that COVID has made it so much clearer than anything else. And for us who are working in the treatment of substance use disorders and understanding what are the factors that plague the challenges, one of them is, again, I come back, criminalization. Why? Because the reality is we know that addiction is a disease of the brain, and we've been able to map the systems, the networks in the brain that are affected by drugs, and how those changes lead to changes in behavior, including the disruption on your capacity to exert self-control, which is incredibly important. I mean, we all have to self-regulate ourselves. I mean, no, I'm not going to get angry. No, I'm not going to stop doing what I need to do. I'm going to do it. No, I'm not going to give in. That capacity that we don't think about it is fundamental in our ability to live our lives and to succeed. If you get it disrupted, then you are a slave of these conditioned and automatic responses. And that can be basically driven very much on this desire, because at the same time, the other element, the other system that gets disrupted is the one that creates a sense of well-being, the one that motivates you, that engages you, that gives you pleasure. And when we feel sort of depressed or dysphoric or anxious or irritable, that system is there in order for us to take action, to get out of that state. When there's uncertainty, when there's stress, that system is activated and it serves a function to do something to get you out of that state. But the way that it works in people that are addicted is the way that they get out of that state is taking the drugs. And if they don't take the drugs, they feel worse. So you have this lack of self-control and this intense drive to get out of a negative emotional stage that makes them very, very sensitive to stressors and very basically irritated and unable to control these strong urges. So within that concept, and you sort of put that together and says, well, I am stigmatized. I basically right now, we've lost a lot of jobs, and people that have problems with addiction have difficulty as is finding jobs. And yet in order to get recovery, you need to actually be sure to be able to get a job or get engaged in social systems that are becoming actually less available. Support systems, community support systems are closing their doors, syringe exchange programs, group meetings. So within this, the concept is how can we use science to address these needs? And I think that that's what we deal with as an agency. And number one, first of all, I do think that we have been, the massive expansion of virtual technologies has been a godsend. And it has provided access to treatment to patients that otherwise we couldn't reach. Not everybody has access to web-based technologies, and so we need to recognize that. We also do not need, and we've heard it from patients themselves or family members, that it may not be the same. So we need to develop tools and interventions that have the capacity to actually not just engage initially a person, but sustain them in treatment. We need to recognize again that we have an opportunity from the perspective of research to create data that could help us modify policies that are driving the way that we treat people with addiction in ways that are not necessarily leading to the best outcomes, such as criminalization of individuals with addiction, or lack of support treatment, or interruption of their insurances when they are released back into the communities. We also have, I think, as a nation too, the opportunity to modify, and I think our ability to recognize the others in ways that I don't think we have recognized them to the same extent. I think that when you're in a situation where all of us are uncertain and where we are losing people that we love, or we lose people that we admire, I mean, it creates a sense of empathy for the others. And I think that moving this towards dealing with the issues that are at hand, which include, of course, obviously COVID, but also the problem that we're seeing with substance use disorders, with mental illness. I don't want to in any way underestimate this, because very frequently they are comorbid conditions, but also too the disparities that we are living, and use this moment and this energy and this attention to change things and to reconsider the priorities in terms of research that can help accelerate that. And I think that we are an extremely important moment to do that.
I think that's such a compelling point, is how do you hold on to the sense of urgency and apply it to other crises in our nation and to accelerating medical progress. If you don't mind, I'd like to start with a question, and then I'm sure that we have others that have come in through the chat. Is there data yet? I know it's been, it's been slow coming, the actual racial and ethnic disparities data in COVID, but do we have any data about the impact of COVID on those with substance abuse disorders, and also the impact of COVID on substance abuse disorder prevalence and outcomes and that kind of thing? Is that there yet, or has that been hard to come by?
Well, the data is basically starting to be analyzed using electronic health records, because we have not had sufficient times. But on the other hand, by now, after basically with the closure in March, we have March, April, May, and start June, in order to be able to look at what of those cases that exist in the United States for which there are electronic records, what is the prevalence of COVID cases in the general population, in the populations with substance use disorders, and to monitor their outcomes. As of now, the research that has come out in terms of analysis for some of this data has basically been limited in any consistent way to tobacco. And even though most of the studies have been reporting that the prevalence of COVID among smokers is higher, and that they have a significantly higher rate of mortality. In some of the clinical reports, for example, from China, it was almost close to double the amount of people dying from that were smokers. There's been a couple of studies, including one from France and a very small study from the CDC, that report lower prevalence among smokers. And they have come to the hypothesis, again, that the reason may be that nicotine itself may have a protective effect. And this is because nicotine does affect the angiotensin converting enzyme receptor that is necessary for the virus to actually infect cells, but it upregulates the receptor. So it is unclear exactly whether it is something that could have a prevention effect or a negative effect. The French are launching a randomized clinical trial to evaluate nicotine patches and see if that decreases the incidence of COVID-19. And we'll find out. I think that there are two elements. I'm not negating the possibility. That's why we do science. And if there is nicotine having a potential protective effect, that's very different from a history of smoking cigarettes, or basically, or even acutely smoking, which is going to be irritating the upper respiratory airway, and which may also be very relevant. We don't know yet. For example, this is a question that we need to do research on as it relates to vaping. We need this information to be able to guide people in terms of what behaviors could have negative consequences, so that they can make choices with knowledge. I think that to me, there's no freedom when you sort of says you can do whatever you want to, but there's no knowledge, so you don't have a sense of the consequences. And so the tobacco, we have started to look preliminary on some of these electronic health records, and what is clear is from these electronic health records, again, it's preliminary, significantly higher risk for getting infected with COVID. Not surprising, because you are likely to not have the support systems that can actually facilitate social distancing. You're going to be engaging in activities to procure the drug. So it's not surprising per se that they are being infected more, but also the outcomes are worse. And we've seen, I mean, from, again, preliminary analysis, all of the drugs of abuse seem to be associated with worse outcomes. And worse outcomes, I mean hospitalizations or death, or basically intensive care unit admissions. And of them, again, preliminary, but I would say the numbers look particularly dire for opioid use disorders, which again, in a way, I'm not per se surprised, because opioid use disorders were killing already, because you couldn't basically transfer oxygen, and COVID is killing because you sort of massive inflammatory reaction in your lungs, among other things, and that interferes with your breathing. So it is, I mean, the numbers from this preliminary analysis are very worrisome.
I just wanted to point out that the example you gave about nicotine, I think is so wonderful for advocates to hear, because it just speaks to science being dispassionate. Science doesn't have a point of view, right? So what you're saying is we got to find out what knowledge tells us, not what we want to believe about this. And I just think that's a really, really excellent example of science at its best, and scariest in some ways, but at its best. So I'm going to turn to Terry, my colleague, with questions from folks in the audience.
Yes, we have lots of questions coming in. One question: what is NIDA doing regarding alcohol use and increased alcohol use and abuse, specifically during COVID-19? Are you seeing anything in that arena?
Well, there is an institute, the National Institute of Alcohol Abuse and Alcoholism, that is actually responsible for all of the research that relates to alcohol and alcohol use disorders. And they are very much evaluating, and there's a lot of concern, for example, because of course that we're seeing an increase in alcohol consumption in our country. And sort of when everything was closed, I could go down the street on my street and buy alcohol because it was open, the liquor store is open until 8 o'clock at night. So people are, and alcohol is an anxiolytic, so it's anxiolytic, so it decreases anxiety. So, and yes, am I stressed? Yes, we're all stressed. So the problem too relates to the adverse effects of alcohol, and in particular concern has been, of course, it disrupts the liver. One of the things that alcohol really damages is your liver, and that in turn has been also associated with worse outcomes with COVID. It also interferes with immune function, which increases the likelihood of you getting infected. So there is research that's not research that's done per se by NIDA, but it's done by an NIAA, and we collaborate and we partner because it is rare that drugs occur in isolation. And what we're seeing with it was clear with the opioid crisis, as people are dying from overdoses. At least 15% of those overdoses were combinations of alcohol with opioids, which makes the risk much greater for you to die. So we cannot separate them, and biology did not separate them so cleanly in terms of, first of all, what we call legal or illegal, or this drug versus the other. You just take one or the other. That's not the way it works. So yes, and our messages too in terms of how in this period of enormous stress, how do we touch everyone and guide and help them guide them in terms of how to provide them resilience and what behaviors, what alternative behaviors we can all engage on, such that the hopelessness and helplessness and anxiety doesn't lead us to do unhealthy behaviors, like consuming excessive alcohol.
Great, thank you. Another question: is there an implication of COVID related to HIV disease management, especially when combined with medications of drug abuse in opioid management? Is there any data on how COVID might affect HIV or activity of drugs to manage addiction?
It's surprising it's not going to be negatively affecting it. And this is, again, a relatively new area because it's a new infection for all of us. So what we're doing at NIDA is realizing the urgency to try to garner information, to be able to ask questions like this one. If you have, if you are HIV positive and you have a substance use disorder or not, and you get COVID, what are your risks? And how do the medications interact with one another? Extraordinarily important. So we've put in a request for supplemental urgent supplements for researchers to be able to address what are the unique challenges related to the management and the treatment of individuals with substance use disorder, and with comorbid HIV or hepatitis C, which is also very frequent among people that inject drugs. And two, with suicidality, which is also very, very frequent among people that are addicted, particularly to opioids. So understanding that, and so one of the targeted areas is comorbidity with HIV, as well as hepatitis C.
Great. Another question, and this is one I think we're all wondering: how do we convince the public, and especially minority populations, to place more trust in science?
Well, I think that again, I mean, you're putting the point there. I mean, how do we get someone to trust science? I mean, when we get sort of actually the science, as Ellie was saying, is something that it basically has no preferences. Science tries to get objective data independent of what I want or don't want. And one of the elements that we do need to consider, because I find myself sometimes catching myself in terms of, we are faced, with multiple pieces of information, and how do we choose which one to trust is not just based on what we think is more accurate in an objective way, but there is an emotional response to it, and we have to all be aware of it. And of course, when we are stressed and we all want to believe that there are these miracle treatments and drugs, I want to believe on them, of course. And so you have to be self-critical, and when you are assessing information, you need to actually determine to what extent actually I'm being objective or not. So one of the aspects is we have to realize that we have never overall, in terms of the education, put the level of emphasis that science should have as a mode of seeing the world. Not necessarily just as a career, which is a wonderful career, and we want to encourage young people to go into science. But if they don't go into science, to recognize how extraordinary valuable it is, and how for the population, but also for each one of us in terms of our decisions. So it has, right now, as we're dealing with the COVID, I think that the component that we've always taken is we're very objective, and we present the data without I believe this or I believe that. And when we're asked about our belief, we very explicitly said this is just a subjective statement, it's not based on data. So we try to do it in a way that is clear, because that's the other problem that I feel that happens with science, that the information is presented in a way that's so confusing that you just block it out. And that has been very detrimental in terms of getting people to pay more attention to science. So I think that we can improve on the way that we communicate scientific findings to the population, realizing also being sensitive to this issue of when people are stressed and anxious, they're much more likely to believe things that are going to prognosticate in general a positive outcome. So they may have more bias towards data that is positive versus data that is negative in general. So being able to be aware of that when we communicate. But I think it is honesty and candidness and information, data. I mean, present the data in ways that are clear. It doesn't need to be complicated. Through basically figures and diagrams can present extraordinary complex data in ways that is very intuitively easy for us to grasp. And we should do that.
Well, I wish we had a lot more time. One thing I wanted to say very quickly just about the last question is that I think we just need to be very careful. At least our survey data, we haven't seen that there's a difference in science trust between minority populations and the overall populations. There's a science trust issue for a part of our population, but I'm not sure it breaks down by those demographics. And so, just again, dispassionate science. But I think we really, all of us have, as advocates, have a responsibility to to work on the issue of trust. And Dr. Volkow, thank you so much. It's been an absolute pleasure. I don't know if you're able to stay with us for the rest of the meeting. Congressman Kennedy is joining us, Patrick Kennedy. Patrick, I don't know if you're on the line. Maybe I made this up in my head.
Can you see me? Can you hear me?
Oh, I can hear you. I can't see you.
Oh,
Are you?
I'm trying to. So,
See if you can.
Oh, there we go. Can you see me now?
Can folks see Patrick? I'm having trouble, but
No.
that could be me.
No.
Yep.
Oh, there we go.
There you. Oh.
I had to Nora. So
Hello, how are you?
Good to see you, Ellie. And
It's so good to see you. And who is this little
colleagues.
one?
Yeah, Marshall.
Marshall.
Marshall, yeah, he's looking out for the Marshall Plan, where we take over the way we do science in the country and save all of humanity in the process. That's the new Marshall Plan. So
Perfect. Well, I think we should hear from Marshall today a little bit more about that new plan.
well,
it's
yeah, go ahead.
amazing that you could join us. I don't think you need any introduction. But we'd love to hear your perspective on kind of your priorities for your foundation and whatever you'd like to address about Dr. Volkow's remarks. Just floor is yours.
Well, thank you so much. I am honored to follow Dr. Volkow, who's a real hero in our field, has done so much to end stigma by elucidating the whole biological and genetic components of addiction, and thereby taking this into the medical realm. As many of you know, when I authored the Mental Health Parity and Addiction Equity Act, the whole premise is that inpatient in-network, outpatient in-network, inpatient out-network, outpatient out-network, pharmacy, and ER, that we were being treated like the rest of the medical system when it came to the treatment of the most prominent chronic illnesses affecting mortality and morbidity in our country, mental illnesses and addiction. And it really is shocking still when I think about it that it's taken us this long to really apply what is so basic to our understanding, and that's the brain's part of the body too, to our whole medical system, into the training of our whole medical profession, which doesn't get trained on these illnesses, to the application generally to all that we know about prevention, all that we know about in terms of chronic care management, everything that can be applied from the rest of the cardiovascular disease world and the cancer world and all the rest to our world of the diseases of mental illness and addiction. So I really thank Nora and her colleagues at NIH for doing so much of that work, and now focusing also on service research. So as we know at Research America, you know, research can come in many forms, and it's really important that NIDA is really emphasizing service-related research now, especially given the fact that the biomarkers, quote unquote, for addiction and mental illness are often things that, you know, are not the A1C, but are having the same relevance as A1C in terms of a corollary to your mental health as it relates to your addiction and your management of your addiction. So that thanks to digital technology and the ability to monitor my facial recognition, my voice intonation, how much I move, how much I sleep, how much I talk, all these things that can be fed into this kind of new, you know, computer, which is our cell phones, and spit out what is a new A1C level for mental health and addiction. These are revolutionary things that will help payers recognize that there's real value for them paying for mental health, which of course it's the federal law for them to do so anyway. But of course, I always like to show them that it is in their interest to do this. And of course, Nora, in her description about comorbidities in mental health and COVID, really illustrated the fact that you cannot divorce this from overall physical well-being, and in the parlance of payers, divorce this from total cost of care. And so I really appreciate the opportunity to be here. I knew that no one would pay any attention to me unless I had this adorable baby next to me, because you were all waiting for him to do the next thing. And so you're forced to pay attention. So I give all credit to Marshall right now.
Patrick, can I ask a quick question, just for those of us who are not as well versed? By A1C, is that a biomarker of improvement that is used for things like payment or research, or the term A1C?
Yeah, no, it's not. I just use it as an analogous, because, you know, in parity, we're always trying to find the analogous disease type in parity to other medical disorders.
I see.
So if we really push for outcomes-based research and deploying what we know works, we have to have the equivalent of how are you doing. In the past, all that you could measure was how did the person report that they were doing. And of course, that was very inaccurate because they lied and it was difficult to reach them. So now we have technology that can help fill in that gap for us.
I see.
And it's really our job in the private sector. But, you know, thanks to Nora and her shop, they're really looking at demonstrating this through certain technologies. You know, and for example, contingency management. This is a field of science that is so embedded in research, but has had no application in the real world of addiction management. And that is, how do you reward people for taking the right behaviors? You know, so Nora went into the biochemistry of the reward mechanisms, as well as everything else. And so we don't have payers adhering to that. Now, I live now, since I left Congress, in Atlantic City, New Jersey. And believe me, the casinos know just how to get you to spin that wheel one more time. And we need to have that same science applied to, we need people in recovery to quote unquote spin that wheel of recovery one more time, and they get rewards. And initially they're very simple. They're many instances just monetary rewards in various forms, but it's enough to spark that gamification of recovery that frankly is not found in most recovery places these days.
What an interesting, I love that analogy, to spin the wheel, you know, and where you're going to incentivize the next step in recovery or treatment adherence. That's just terrific. Patrick, I know you didn't have much time for us. Do you have time for questions, or do you need to run?
No. Marshall is clearly not at all interested in anything I'm saying right now. He is totally bored stiff. So I imagine most of your audience is sleeping as well. I've just put you to sleep.
I've got to doubt it. Now, before I ask one of my million questions, Terry, are there any coming in through chat?
Not yet. I encourage the audience, go ahead and put those questions in the question box. So Ellie, if you have a question, go ahead.
Great. I do. Patrick, for individuals who are in addiction recovery, but have a comorbid mental health condition, let's say it's ADHD, severe ADHD, so there could be some loop, right? But because they have an addiction, they may be not either able to or not being prescribed medicine for their mental health condition. Have you all looked into that and how to deal with that kind of complexity?
Yeah, well, as you know, there are huge gaps, obviously, between the medical system and the mental health system. But of course, there's huge gaps between the mental health system and the addiction system. And then, of course, there's huge gaps between both of those and the recovery system. And the recovery system really benefits people with both mental health and addiction, and could be applied to both. So it could be a system that really is universal, and we should build out that infrastructure. I have proposed
That makes so much sense.
Yeah, I would propose that we take all of our folks who are starting in recovery, and we really start to emphasize peer support recovery. There's so many people out there who need services. We just don't have the supply of professionals to deal with that. Everyone also knows that peer support's as effective as almost anything, obviously in conjunction with psychopharmacology and obviously good incorporation into the overall health management through an EMR, which is why I was really for the override of 42 CFR, and we need to get that complete. Anyway, so yes, I mean, I have a tough time negotiating an ASAM doctor because I have both an underlying depression and anxiety disorder with addiction. And in the past, my psychiatrist really didn't have the same appreciation for addiction the way my ASAM psychiatrist has an appreciation for it. So and of course coordinating that care, and like I am always fighting for, getting that care reimbursed. It just makes this harder to do than the what are the games that they have on TV, the X Games or whatever, where they're trying to jump through all of those. They should have the X Games for jumping through all the insurance obstacles and loops. So.
Yeah, because that's going to, without that, the integration of these different providers becomes that much harder, which that makes sense. You're doing work in California that is a whole new paradigm, isn't it, for mental health care? How is that going?
Yeah, so encourage people who are interested. I've just partnered up with smarter people than myself to put together One Mind for Research, which, as we all remember, our great leader, Steve Hyman, who has been a champion for us. And we have many others who he's coalesced to really incentivize more young people going into research. And that's but we've really pushed this idea of a depression grand challenge, which of course UCLA has really embarked upon. We need to have the same thing that cancer has in terms of the NCI. We need to have for depression. Depression comes in many forms, like autism, it's a spectrum disorder, and anxieties are spectrum disorders. And we need to have major, kind of nationwide longitudinal studies. The biggest challenge I can make to our country for what will transform mental health care is for more people to participate in research. The brain is the most complex organ of the body, as we all know. That means we need more data points in order to see the algorithms and to identify the patterns in the response based upon people's genome, phenome, biome, metabolome. We need to connect that science, and it's going to take like a NASA kind of a race to inner space where we integrate all of those data into a replicable kind of cohort of trial, so that we can see this not only in the United States, but we can encourage our friends in Europe, Australia, other parts of the world to likewise follow those same protocols, so we have real replicability in the science, and we can really tease out the data by genetic predisposition, by to severity level, by type of disorder. That should be our goal. And I'm honored to be, working kind of peripherally with the Biden team on this stuff. I hope we can get as much of it in with his people. And I thank Research America for helping sensitize me to all of these facts.
Just terrific. And I think, as I recall, depression maybe, is it the third, one of the third most prevalent disease globally? I mean, it is up there. And so your point is so well taken. Well, we've been absolutely honored. I need to do a little bit of housekeeping, but we've been so honored to have you, and so great just to see you. It's been too long.
Thank you, Ellie.
So thank you. Thanks so much.
You bet.
So I am not going to keep you all much longer, I promise. I just wanted to mention that there is a new opportunity, and that is to sign on to endorse legislation called the RISE Act that would provide about $26 billion and change in research recovery funding to supplement grants that have been depleted because of the stalled research that was necessitated by COVID. I think you all know the reasons why there is such a gap in funding for us to basically start turning the wheels again on research as soon as possible. And so Congresswoman DeGette, Congressman Upton, it's a larger group of co-sponsors, very bipartisan, have introduced this bill, and they're looking for endorsements from organizations. And if anyone is interested, any org that is, whose representative is on the line is interested in endorsing, please shoot me an email, Sarah, Anna, Jenny, anyone from our team, and we'll make sure you get the link. And I think that's it for me. Are there any other questions or comments for the good of the order? Well, thank you so much for joining us today. I think it's been a great, for me, it's been a great session. I know I asked most of the questions, but thanks to you all. And again, thanks for your membership in Research America. We really appreciate you. Thank you, Patrick.
Bye-bye.
I think we're shutting